Welcome back to part two of Understanding Central Control Mechanisms of the Autonomic Nervous System, a conversation with Dr. Kevin Lasko. If you missed part one, pause here and catch up on it by going to the linked card above. Also, be sure to subscribe to our channel to get notified of new videos. We're joined today by Dr. Lasko, a board certified chiropractic neurologist in Pennsylvania. He's married and has 4 children. He's a fellow of the International Academy of Chiropractic Neurology and has obtained certifications in childhood neurodevelopmental disorders, functional imaging and anatomy, movement disorders, and most recently, the treatment and diagnosis of dysautonomia in 2022. Dr. Lasko is a presenter for the Ehlers-Danlos Society Project ECHO and has significant experience in treating complex patients with Ehlers-Danlos Syndromes, dysautonomias, Chiari Malformation, Mast Cell Activation Syndrome, and more. He truly is passionate about helping improve the function and quality of life of those with EDS and dysautonomia. Now, Dr. Lasko has graciously agreed to answer questions that you send in another talk. To have your questions answered, please send them to educationteam@dysautonomiasupport.org with the subject line Dr. Lasko, and we'll include them in an upcoming Discovery Education video with him. If you have more questions of a personal nature, Dr. Lasko is willing to connect with you. You can reach him by email at lasko.hemispheres@gmail.com, where he'll then set up a free 15 to 20-minute call to discuss your particular questions. So let's jump back in. Circling back to kind of where we are at the beginning. So current treatments, they might dampen things at the end organ, but again, it's not decreasing that pathway or that sympathetic pathway. So the sympathetics are still firing. So even though you might have a decrease in symptomology because of the medication, the sympathetics can still be out of whack because either the parasympathetics haven't gone or there's just that high sympathetic drive. But by doing these exercises or the exercises that could be given to a patient based on their assessment, it can then help to kind of get better into balance and kind of not correct, but through developing neuroplasticity, it ends up reinforcing good pathways instead of the bad pathways.
Yeah, I mean, and that's the ultimate goal because all of a sudden, if your heart rate starts to come down, you might not need as much of a beta blocker. And there's some of the things that can come with that. I would never tell somebody just go stone cold, don't take them. That wouldn't make any sense. But it's nice to have a working relationship to say, listen, I'm functioning better in this aspect. I'm taking this for that aspect of my dysfunction. Can I decrease it and see how I do? I think that's the ultimate goal for patients, no matter what you have. You know, there's when your brain functions pretty good, you function pretty good.
Mhm.
And if those and if it can do what it's supposed to do, um, it's going to respond in a correct manner as well as it possibly can. And that's the ultimate goal. I mean, I don't think anybody walks in the door saying, I want to be perfect, whatever that is. They want to be functional. They want to be able to go to the movies. They want to be able to go for a walk with their significant other, take the dog for the walk. They want to go get the mail. They want to go out to dinner. I think you could do that. I think you could definitely live with this
Mhm.
EDS, dysautonomia, all of that. It's just you. I just think us as clinicians, we have to do a better job of getting very specific with the person and not just kind of saying, let's try this, because you're going to have good and bad. And I think we could do better.
Well, and oftentimes it's difficult because, we are presented with different what we understand as best practices of things to do. And, oftentimes it starts with increasing salt and fluids, which, we have studies out now that have shown high salt diet can decrease symptoms in patients with POTS, even though it doesn't put us within the normal range. It doesn't get rid of our POTS, but it does help decrease symptoms. But even exercise, these protocols that, yes, exercise is incredibly beneficial. Movement is beneficial. As you said, we're sensory driven, so that movement is important. But oftentimes it's hard for us to adhere to some of the exercise protocols because of exercise intolerance and symptoms that go awry. So, in theory, by partnering a lot of what you do with working centrally to kind of change the functioning and the neuroplasticity with the sympathetic, parasympathetic, and enteric systems, then the treatment or the different lifestyle changes can be more effective because then we're able
Yeah,
to tolerate them more.
yeah, I would agree with that. If there's one thing I would say about just like that topic about exercise and that realm is you have to get moving. You have to, I mean, that drives the whole system, right? But you you don't want to take a 2 month old and stand them up and say walk. They're
Right.
going to face plant. They're going to fall. They're going to get hurt. And if I hope the group here gets that is if if you're if you're walking on a treadmill, you know, walking on a treadmill is great, but not if your heart's ticking away at a buck 80, and then you did your 20 or 30 minutes. Great, okay. But how are you the next day or the day after? Most of the patients I see, I hear this all the time. I did it. I had to cancel an appointment. I was in bed for a day and a half or 2 days. I
Mhm.
tried to do it again, and it was like rinse and repeat. You're on like a roundabout. You just keep going around. And my thought process is I think that type of stuff, you're exceeding that metabolic limit. I use really dumb examples, but like if my wife were to say go to the store, sure honey, I'll go. And if she starts rattling off bread, eggs, milk, salad, chicken, this, gives me 30 things without a list, I'm going to say I'm going to go, I'm going to walk into the store and say what the heck did she ask me to get, and I'm going to get a Kit Kat bar. I mean, that's all that's all that's going to come out, right? But if she says, "Can you get bread, eggs, and milk?" Right? I may still screw it up. I may get whole milk. She wanted 2%. Might get white bread. She wanted French. That's easier to correct. And what I'm getting at is like you need to be able. There's certain levels I think of how your body functions that you have to make sure you're good at that level before you start going to the next rung up on that ladder. And
Mhm.
if people that have dysautonomia, if you can't maintain like basic homeostatic function, like sleep, eat, digest food, get rid of waste, maintain a decent heart rate, deliver blood so your hands and feet aren't freezing cold. You could have a conversation for more than a couple minutes before the brain fog kicks in. All of those things. I mean, think about if you can't do most of those things correctly, how much do you want to tax your system more by doing exercise? Even though exercise is good, you know, it you it there's a time and a place for all of this stuff. I mean, another just to kind of pound this nail in a little bit more, you got a first grader that thinks an 8 is a snowman and a
Mhm.
1 is a stick. You're not going to do long division with them or multiplication anytime soon. They're not going to get it. You need to make sure they know the basic numbers first before you can go over to more difficult math. And I see that a lot with the patients that I see because they have 2 arms, they have 2 legs, just go exercise, go do this, but they can't, but they fatigue so quick because they don't deliver blood because their autonomics are not functioning well yet.
So, in other words, through doing the exercises, not exercises as in exercising at a gym or cardio or anything like that, but through doing the therapies and protocols to help address the dysfunction of dysautonomia from a central perspective. So I'm talking about those exercises.
Yep.
In doing those first, you can then get the autonomics better under control so that when you layer on the different either, just even physical exercises,
Yeah,
cardio, and things like that, it's going to be tolerated better. Again, still being mindful of metabolic demands and how the body is doing, but it's going to be tolerated and then I think much more effective because you've maintained a better balance of the autonomics first.
right. And I think every patient that I see, I always tell them, you need to get up and do stuff, but you need to be ready to get up and do stuff first. And yeah, I mean, that's what I try to give patients when they leave. Like, this is kind of the stepwise thing. Like, when you get to this level, you can start trying to do these things. When you get to that level, you could start doing these things. But you're 100% right. You still have to maintain basic homeostatic function, and that's heart rate, blood delivery, all of that stuff, gut function. Yes.
Right.
Yep.
I know with my friend, it was quite difficult because being so sympathetically driven, just every little thing would send the heart rate soaring. And so it was a pullback of
Mhm.
a lot of stuff and very just basic, stand up, and just standing up, heart rate would go, to 120. And it took a while before there was that better, I think, control of the autonomics there, but then gradually things were able to be added up and functioning improved. So it's great to see when, this definitely works with patients, but it does take persistence and it takes time and patience.
Yeah, and I think, and most patients, know this, but they don't kind of think this way. Um, Dysautonomic patients have been probably sick for a long time. I mean,
Mhm.
they haven't been functioning well. They've been pushing through it because they have to. I just need to keep moving. I need to do this. And when you kind of, when you ask them, when did this really start, and if mom is sitting there significant, oh my gosh, she's had this since she was 7 or 8 or 12 or whatever, and I'm looking at a 30-year-old patient, that's 15 years ish that you've been getting, like, 1 plus 1 is 9 coming into your system. It takes a little bit of time to change that perception of what's normal is, even though you've been abnormal, but it becomes a normal thing for you. I
Becomes your
stand up,
normal,
yep,
yeah.
yep, my heart rate's gone up to a buck 40. We'll just hope it doesn't get completely black and I could just keep that tunnel vision so I could see. It takes time to change that and how your body works. But what I found, if we do the exercises and we see changes in the autonomics, whether it's heart rate, perfusion, gut, whatever, sleep, you're changeable and the system can be activated and you're going to see improvements. I could never tell you it's going to be a week, a month, 6 months, 2 days, whatever, because that's based on your system and that's that individuality. But if we see a positive change, you're changeable, and
Right.
that's always a good thing.
Have you ever had patients that end up going on not needing to do the therapies that you prescribe to them?
Yeah, all of them. I mean, I'm gonna some of the exercises I give my patients, I do every day because I know that I know how the system's going to break down. As we get older, the system breaks down, and it's always good to have that, almost like a neuroprotective thing going on. Like, I do different eye exercises every day. I do different arm exercises every day because I know what the breakdown is. I do postural stuff every day because I know I don't want to be the 90-year-old guy all hunched over. I want to be able to resist gravity. So some of them do. I mean, some of them respond tremendously well. But I think when they see that improvement, they still want to. They know where they came from, and they don't want to go back. And these exercises are not like joining Gold's Gym, Planet Fitness. They're things you could do. And I joke around with patients, on the toilet, waiting for the toast to pop up in the morning, waiting for the coffee. these aren't like demanding things where you got to spend thousands of dollars to go join a gym. These are simple exercises that if you just do them consistently, daily, you could see changes.
It's interesting, that concept of kind of even thinking for quote unquote healthy, normal people, because I think we all have some form of dysfunction in
Oh
our
yeah.
lives in some areas. But in being able to then almost have this neuroprotective effect of, potentially doing exercises to help activate certain areas within your brain or inhibit certain areas to then promote health and longevity throughout your life.
Yeah, that's not a bad thing. you
Yeah,
know, and I just think it's important because of, I mean, 90% of us probably had some sort of COVID or COVID variant. I know it affected me, and I'm trying to do stuff to maintain a better lung capacity, heart, and all that because it kicked my butt when I got it. I mean, it really did. So yeah, I mean, the breakdown of of the system, it happens to everybody, and generally as your brain function starts to decrease a little bit, and that could be from injury, that could be from bad input, that could just be from age,
mhm,
um, we start to lose those inhibitory mechanisms and you start to see those escapes. And that could be for the 80-year-old guy saying, hey, Kevin, you couldn't put a tie on. You knew you were going to be on with Leslie. Like I cleared it with her first. She said it was fine. Um, to the just that real crotchety kind of a person. Well, you shouldn't be like that. But why are you? It's because you can't inhibit a correct functioning brain. You shouldn't, who cares? You don't comment, why are you wearing those shoes today? Well, because I wanted to. Who cares? But think about this. It's that type of function is what you see in a very small child as well, right?
right.
You're at Toys R Us or wherever, and you're carrying 3 toys, and you say you could pick one, and they have a fit right there in the aisleway, right? They're kicking, screaming, and all that. Why is that? The little one, the brain hasn't developed yet to make a choice and inhibit that. I want everything. The older person, it's starting to go down because they're not as active, all that. They're not golfing anymore. They're not walking, whatever. And the brain is starting to go down a little bit. And you get the same type of a response. And
So
it's
that
that lack of inhibition.
that reverting back to childhood, and
Yeah.
then in a lot of ways, then I guess continuing that analogy, a lot of our autonomic nervous systems are kind of barely functioning like we're 2 months old.
And I look at that a lot. And I kind of, in my head, I look at, you can have a 25-year-old male, female sitting in front of you, but if their heart rate's a buck 20 sitting there, where in that developmental scale are you? That's a newborn, right? Oh my God. Oh, I can't eat anything. I go too much. Where is that on the scale? That's pretty much a newborn, right? Oh, I don't sleep. Any sound I get startled with. That's, you got the baby, you put them down for a nap, you hit that wrong floorboard and it creaks and they're up. You're like, oh my gosh. That's the startle response. That's 6 months old. So and I really do. I look at a lot of my patients like that. Like, if a, we have a grandson, he's just learning how to walk. He's like 11 and a half months. It's really cool. But you know what? He'll reach out and touch things occasionally to make sure he knows where he's at. How many people with dysautonomia,
Hands
ADS,
raised.
have to walk through things and kind of touch them or bump into things as they go through a door or walk their significant other off into traffic, when you're walking with them? Where are you on that functional scale? And I really look at it like that. And that kind of tells me where we got to start at with treatment.
And then go from there. And so,
Yeah.
with all of that, we're looking at those kind of central control mechanisms. So,
Mhm.
can you explain a little bit more about those mechanisms, things such like the brainstem, the basal
Sure.
ganglia, and
Sure.
how all that interrelates with our autonomic nervous system?
Sure. Red is going to be inhibitory, green's going to be it's excitatory, okay? And everything else is going to be blue, okay? So just one of the reflexes that occur with like maintaining heart rate and blood pressure is the area responsible is the baroreflex, and that comes out of your carotid sinus. So that would be like one of the carotid arteries. You have one on each side, and these things here, they're big 25-cent words, but the nucleus tractus solitarius is like a sensory post office, if you will, in your brainstem. This is the nucleus ambiguous, which is the nuclei for your vagus nerve, which is a big parasympathetic nerve. This is the rostral ventral lateral medullary area, and this is the big sympathetic nucleus in your brainstem. So that is tonically active, meaning it's always on. Okay, because we need sympathetic tone. Okay, we need our heart to beat. It can't just not beat. So that's the heart. That's the heart. That's a blood vessel. All right. So what happens is in this, your baroreceptor from the carotid sinus, okay, fires in to this NTS. So this is input to say how much pressure is in your carotids to pump blood up to your brain, because that's the main thing. You got to get blood
Mhm.
up north. Okay, so this excites your NTS. All right. Now, the NTS is pretty cool because it talks to all of these autonomic control areas in the brainstem. All right. So, what ends up happening is one branch out of this NTS fires down to your nucleus ambiguous and it excites it. This turns into the vagus nerve and it decreases heart rate, right?
Mhm.
Vagus nerve will decrease heart rate. Okay, so it excites the heart, but it inhibits how much it beats. Okay, so the other thing that happens, this NTS also fires to this area here to excite it, to keep the heart beating, which is kind of important. And this will fire down to the heart to excite it, to increase heart rate. And then it also fires down here to your blood vessels to do a little bit of vasoconstriction. So you could maintain some sort of blood pressure. All right. Now this is the key thing, and this is where that lack of inhibition comes in. This area also fires down to this area to excite it, but what happens is this caudal-ventral lateral medullary area fires to the rostral ventral and it inhibits it. Okay, so I know we drew all this out, but what this means is you get input from your carotid sinus to say this is the pressure on my artery, right?
Mhm.
The main thing is how does your heart should respond in a correct manner. So it gets input from your nucleus ambiguous and your vagus nerve to say, I want you to slow down. It gets input from this RVLM to say, I want you to speed up, and it comes to a nice homeostatic function, right? This constricts some of the blood vessels, which is this one over here, if you want it to be, to maintain normal homeostatic function. But it's all based on this guy talking to this guy, right? This is tonically going. This wants to just run. This is your sympathetics. All right. So
Hmm.
if you lose this inhibition, what happens to your sympathetics? They
They
just
keep.
run. They just run. And the thing that drives this is the input from everything else coming into this NTS. Now, I know this is deep, Leslie, but this is your reflex. This is brainstem. This is lower brainstem. This is how your heart contracts. The difference, if you will, between what your vagus nerve is telling the heart and what your sympathetics are telling the heart to do to maintain homeostatic function, and what is the function of that heart rate on your blood vessels. Because this is a pretty cool thing, and I'll give your listeners, well, I don't know what I'd give them, but it would be pretty cool. A little question you could ask them, and don't Google it and get the right answer, but what's the parasympathetic innervation to your arteries and veins in your periphery? There is none.
Hmm.
There's no let that settle in. And I mean, really think about that. There's no parasympathetic innervation to your peripheral arteries and veins. You have some parasympathetic innervation in your brain, around your heart, and like in the sex organs, but in your periphery, there's no parasympathetic innervation. So somebody that has POTS, or maybe blood pools, or their blood pressure goes up, any of those, where are you going? How can you get, let's just say this, if these really vasoconstrict, right? How are you going to get them to vasodilate to get some blood going to your extremities?
You
You
have to.
can't just say activate the parasympathetics because there are none going to it. You have to create some inhibition of activating this to decrease the tone of your sympathetics here. So if you lose this inhibition, you're going to have higher sympathetic tone. The input into this NTS is pretty much everything. Anything sensory comes into this NTS for the most part. This is the big thing here,
Right.
because you know what talks to this here? This is everything cortical. This is cerebellum, vestibular, higher brain centers, basal ganglia, midbrain, prefrontal cortex.
So if that input is wrong or wonky, then you're not going to be able to then potentially excite the CVLM, which causes that inhibition of the RVLM.
Why the heck am I here? Just do this.
So that's where you have the dysfunction. And so basically, you're able to, with that neurological examination, through even assessing cerebellar function, cortical function, being able to see where things are wrong, and seeing how that impacts then the NTS. And so through identifying where the dysfunction is, you're able to give exercises that can potentially cause that excitation of the CVLM to then start that inhibitory process of the
Yeah,
RVLM.
yeah. And there are other, I mean, this is very basic, and I'm not like that, but you have inputs into here that don't necessarily go through this, but this is just a very basic kind of talking about why that lack of inhibition is where the problem really is with a lot of these dysautonomic problems, is because you're talking dysautonomia, you're talking heart, peripheral blood vessels, gut. I mean, this is your sympathetic chain. This goes all the way down. This delivers blood to your body
Right.
everywhere. Okay, the heart is the pump that helps deliver the blood to everywhere in your body. If this thing is not inhibited in a correct manner, you get higher sympathetic tone.
Right.
Just plain and simple. And it's all kind of predicated, I want to say all, but it's really predicated on how much this is excited to inhibit this to get a normal output based on the totality of what's coming in here.
And so then with, again, reiterating, treatments that we're doing now, again, are focusing on the end organ. They can block certain signals coming to the heart to decrease that heart rate, but you're still not doing anything about that excitation of the CVLM to then inhibit the RVLM to then decrease sympathetic tone when it's going haywire.
Right. Like all this is still going, okay, I'm gonna stop here. The sympathetics are saying, I need to run, I need to run, I need to run. Oop, I'm not gonna run because some of the receptors are being blocked here.
Mm-hmm. So even then, with some medications that we take that can potentially work with vasoconstriction to help increase blood pressure, would that then sort of still have input because then the baroreflex and the carotid sinus, because it's changing that vascular tone to increase
Oh,
it.
mm-hmm.
So I'm trying to process it through. So then if that is different because of medication, you still can potentially not have the excitation of the CVLM, which is causing the inhibition of the RVLM.
Or you're gonna get what they like. So a beta blocker is gonna slow this down, right? It's gonna
Mm-hmm.
slow the heart down. Okay. You take midodrine Florinef, that causes some sort of vasoconstriction out here, correct? I mean, that's kind of
Florinef
what it
works in a
does.
different way, but like midodrine and some of the others
Yeah,
can cause vasoconstriction.
midodrine can give a little bit of vasoconstriction. So you're getting this feedback loop kind of correct based on how the medications are running this show, right?
Mm-hmm.
But what does that do to all the other inputs into here? How does that affect this?
So it's still then
And it's
other
pretty
factors
big.
that drive
Yeah,
the system.
yeah. Because we see patients that are on those meds, and we could change how their blood pressure, heart rate responds doing these sensory, somatosensory type of inputs. Well, nobody's altering how much beta blocker you're taking. Nobody's altering how much midodrine or salt you're taking, but we could still do different therapies to areas that affect this area that can get a correct output as well. So
Mm-hmm.
if you could do that in a correct manner, could you potentially decrease the need for the midodrine and the beta blocker if you could get this whole system working in a different manner by using different sensory inputs? I could say yes because I've seen it a bunch of times. I mean, hundreds of times. But yeah, this is really in a nutshell. I mean, you have different, and if you have different inputs into this RVLM from your dorsolateral pons, like A5 and adrenergic receptors. You have a ton of things that come into this. This is just very, I mean, like crazy basic, like 101. But and that's why I think doing a good neurologic exam and seeing where does that system break down is so important because there's so many inputs into this and there's so many inputs into this NTS. And if you could alter the output of this, especially to here,
Mm-hmm.
you could alter how much tonic excitation you have on your sympathetics.
Which then leads to improvement of symptoms
Yeah. Yep.
and better functioning. So just to wrap things up and conclude, today we have talked about a new perspective on looking at the treatment of dysautonomia. So instead of looking at things from that end organ approach where interventions just target specific symptoms, and aren't really addressing the central control mechanisms of the brain, we've discussed how your treatment, your assessment is able to kind of fine tune the dysfunction in each patient. And then from identifying that dysfunction, you're able to then prescribe different therapies and exercises that a patient is able to do to help improve those symptoms, develop that neuroplasticity, and then increase and have a better quality of life. So this definitely is a different perspective on treating dysautonomia than what we currently are seeing out here today. So, Dr. Lasko, what do you hope or what do you think the future of dysautonomia treatment will look like?
Yeah, I think we're starting to get a little window into it, because there's consensus papers that are out there, and it's basically, um, you know, end organ peripheral type of treatment. But we're starting to see research projects and like doctors writing papers on these central control mechanisms. And I don't have it on me, but I would definitely make it available. But I mean, there's papers out there that basically say, hey, is POTS, is there a central mechanism in POTS or orthostatic intolerance that we're missing in the treatment of these patients? So I think this is coming out. I think we're getting there. There's groups that are really looking into this, but again, you got to do the studies and all of that to get this really out. But just from my experience, people that have orthostatic problems, there's definitely a central component that's driving some of this. And I think that at least has to be addressed with the providers or work in conjunction with some of the providers that are doing the meds and that route, which is fine because you need to get over the hump. You need help with that. But as long as there's a good working relationship between both of them, I think that's going to be best for the dysautonomic group. So
That more holistic care and approach to dysautonomia.
yeah, I think that's always good.
Well, I do too. Awesome. Well, as I stated at the beginning, Dr. Lasko has graciously agreed to answer any questions that you guys might have in another talk. So if you send us your questions in an email to educationteam@dysautonomiasupport.org with the subject line Dr. Lasko, we'll be sure to include them in a question and answer session with him in an upcoming Discovery Education video. Also, if you have more questions of a personal nature, you can reach out to Dr. Lasko directly at lasko.hemispheres@gmail.com, and then he'll get in touch with you and set up a call to discuss your particular questions. So thank you, Dr. Lasko, for joining us. It has been a pleasure, and I'm excited to see where the future of dysautonomia treatment will go as we kind of look at things more centrally.
Thank you very much. I really do appreciate it. I hope this was helpful, and have a good day.